Welcome, everyone. Thank you for joining us today for our Grief Sensitivity Virtual Learning Institute. This is the first part of a two-part series. The focus of this institute is on supporting those individuals experiencing grief and loss during COVID-19 and beyond. We're so glad that you're here today. Again, welcome. Be sure to put where you're from and who you are in the chat box. Today, our session is titled Understanding Grief and Loss. I want to thank our wonderful speaker for being here with us today, and a big thanks to all of you for joining, and truly hope you find the presentation both interesting and informative. A few housekeeping items. We are taping this session. We have tried to make it as secure as possible. If for any reason the presentation unexpectedly ends, we will follow up using your registration information. All the attendees are muted, but you can certainly interact with us in the chat box, and please put your questions for the presenters in the Q&A. We are closed captions, so if you click on that CC box at the bottom of your screen and choose Show Subtitles, you will see the subtitles. To change the size of the subtitles, click the arrow next to the CC box and choose Subtitle Settings, where you'll find the option of making the subtitles smaller or bigger. And if you don't already, please follow us on social media and stay in touch with us. We encourage you to take care of yourself today during this web series on grief and self-care. We encourage you to drink plenty of water, get up and stretch when you need to. Because this topic is very sensitive, we have included helplines here for support in case any of you need them. Again, we have uploaded additional information on grief on our landing platform, which you can access. Kadi will put that information in the chat box for all of you to access. Our fact sheets. The MHTTC network is accelerates the adoption and implementation of health-related evidence-based practices across the nation. We offer resources and technical assistance in all regions across the United States. There are 10 regions, including a National American Indian and Alaska Native Center, as well as a National Hispanic and Latino Center, and a network coordinating office. This is our wonderful map that you can see, our lovely map displaying the centers that make up the MHTTC network. Again, we have 10 regional centers, so if you look at this map, you can find your center, and then please connect with our network coordinating office, where you can visit our website and find your center, so you may stay up to date on trainings and resources that are offered in your region. Just a disclaimer, the information that is presented herein is the discretion of the speaker. It is not the express views of our sponsoring organization, which is SAMHSA. At the time of this presentation, Eleanor McCants-Katz serves as SAMHSA's Assistant Secretary. Again, no official support or endorsement of the Department of Human Services or SAMHSA is described in this presentation or is intended or should be inferred. So with that, we're going to start our presentation. Today we have with us Dr. Kenneth Doka. And Dr. Doka has a tremendous biography, which I don't know that I'm going to get through all of it, but he is a professor at Emeritus, the College of New Rochelle, and senior consultant to the Hospice Foundation of America. Dr. Doka has extensive experience in the area of grief, is a prolific author and speaker, providing keynote addresses internationally. Dr. Doka participates in the annual Hospice Foundation of America teleconference and has appeared on CNN and Nightline. In addition, he has served as consultant to medical, nursing, funeral service, hospice organizations, as well as businesses, educational, and social service agencies. He was elected president of the Association for Death Education and Counseling in 1993. In 1995, he was elected to the board of directors of the International Workgroup on Dying, Death, and Bereavement, and served as chair from 1997 to 1999. The Association for Death Education and Counseling presented him with an award for outstanding contributions in the field of death education in 1998, and significant contributions to the field of thetanology in 2014. In 2000, Scott and White presented him an award for outstanding contributions to thetanology and hospice. His alma mater, Concordia College, presented him with their first Distinguished Alumnus Award. He is a recipient of the Caring Hands Award as well as the Dr. Robert Fulton CDEB Founders Award. In 2006, Dr. Doka was grandfathered in as a mental health counselor under New York State's first licensure of counselors. Dr. Doka is also an ordained Lutheran minister. So with that, I'm going to thank you for being with us, and I'll pass it off to you, Dr. Doka.
Thank you. I'm delighted and I'm honored to be here today. And consider quite, wish I could be with you all in person, but that's going to take a while, I think. But in any case, it is nice to be here today. And I guess especially significant to remember that 19 years ago, we had a significant period of national grief. And so we honor and remember that today. What I'd like to do today is talk about understanding grief and loss. And as we go to the next slide, you can see the goals for today. The key questions, really. Number one, how can we understand the experience of grief? And number two, what factors can complicate and mitigate that experience of grief? And those are going to be the two basic questions we're going to focus on today. Question three, how can we help and how can we assist grieving persons? We'll really save for our second session in November, but we will address a little bit of that today. Well, let's start with some basic definitions. I think, we always really try to start there. How do we define and differentiate grief, mourning, and bereavement? I always think about that because the first time I proposed a course at the graduate school in grief, mourning, and bereavement, one of the members of the committee that evaluates new courses asked if that wasn't a redundant term. And in the field, they really are used with very distinct and very separate meanings. So let's begin then with the next slide. Bereavement is what we say is an objective state of loss. So if you've lost your parent, you're a bereaved child. If you lost your child, you're a bereaved parent. It simply refers to an objective state of loss. Bereaved person has lost somebody. Somebody has died or lost in some other way. Grief, though, is defined somewhat differently. Grief is how we respond to that. That's the subjective set of responses or reactions to a loss. And as we're going to see in some depth, these reactions can be manifested physically, emotionally, affectively, cognitively, behaviorally, and even spiritually. And these distinctions are important as we move to the next slide, because one of the things we recognize is that we can experience bereavement without grief. In some cases, we may have had somebody who may have had a role in our life, but maybe not as significant as we experienced. And so at the time of their death, there's little attachment, there's little connection. And even though we may have lost a grandparent, we may not have had any relationship with that grandparent. So we can experience bereavement without intense grief. And certainly, there's lots of situations where we can experience grief without bereavement. A lot of work has been done now on what we call non-death losses. We'll talk about that a little bit later on. And of course, as we move to the next slide, we do experience what we call anticipatory grief, which is a little trickier than it sounds. The original notion of anticipatory grief refers to the fact that that we used to say we often anticipate and begin grieving when a person has a life-threatening or life-limiting or terminal illness. Now we recognize that it's much more complex than that. Therese Rando, one of my favorite colleagues, calls it a useful misnomer. What we're really responding to in many cases are the very real losses as well as the anticipated losses. So for example, when we have somebody who's dying, we may not be able to talk with them in any particular way or deal with them or respond, and we're already grieving. Mourning, on the other hand, has two meanings. The first meaning of mourning, if we can just hit that slide one more time, is what we call the interpersonal notion of mourning. And that refers to the cultural practices and rituals that are associated with the loss. So in that definition of mourning, we're talking about, for instance, the funeral, all the kinds of, the wearing of black, all the things we do to show that we've had a loss. But there's another definition or another way that that term is used, not my preference, but still used that way. And that's, as we move to the next piece on that, the intrapersonal piece. And that's the psychic process of working through grief, which we sometimes also call, and I prefer to call, grieving or grief work. And again, just hit that slide one more time, and you'll see that. As we move on to the next slide, again, much like we did before, and that's why these distinctions are important, we can grieve without mourning. There are many kinds of losses we have in our life that are very significant, such as divorce, that really don't have any mourning rituals. And of course, we can mourn without grieving. Many of us have had the experience of going to a funeral, maybe of a friend's mother or a grandparent. We had no connection, we had no attachment to that person. We feel empathy for our friend and we're there to support him, but we're really not personally grieving, although we publicly are engaging in a mourning process. As we continue, so what are the ways that that persons tend to experience grief? And I'm going to spend some time on this section because this is really important. The first thing we have to do really, or the key to grief counseling, is number one, assessment. In other words, to really say, how is this loss really being experienced by that person? To be able to differentiate when we're dealing with that person, the grief that they are experiencing, and to validate that grief, to say, no, that's very normal and that's very natural. But also, I think to assess, is this grief in the range of what we call typical? Or as we're going to see at toward the end of this presentation, does it really give us pause or really indicate danger? So it's very, very important to really understand the full process of what we might call, or what falls into the parameters of what most people in the field would call typical grief. So if we can continue then. And as we said earlier, and we're going to look at all of these in great depth, grief may be manifested in many ways. It can physically affect us. It certainly can affect us emotionally. We often think about grief mostly in terms of emotion, but as we're seeing today, it's far more than that. It can influence us cognitively. It can affect us spiritually, and it can affect us and influence us behaviorally. And let's start with the physical then in the next slide. Physically, we can have all kinds of issues with grief. When I experience a loss, I often feel it in my stomach, a kind of upset stomach, digestive difficulties. Other people will report things like headaches, dizziness, exhaustion, tremors, you can name it, menstrual irregularities or erectile dysfunction, and all kinds of aches and pains. As a matter of fact, one of my colleagues, Jane Nichols, now deceased, was one of the pioneers in exploring perinatal loss. Perinatal loss, of course, refers to stillbirths and miscarriages and deaths within the first trimester of the child's life, first 3 months of a child's life, since they're often birth related. In any case, so Jane did her work in the 1970s, and if you recall those times, almost 50 years ago, perinatal loss was often overlooked and disenfranchised. If there was any grief counseling or support that was given, it was often in the sense of, you're young and healthy, just go get pregnant again, don't worry about this. There was very little recognition of the grief and very little understanding of the grief. Jane's work was really one of the things that helped us recognize the seriousness of perinatal loss. In any case, Jane did some research and she asked people what kinds of pains they experienced. And again, at that time, and this is what we call conversion reactions. When grief isn't always acknowledged or recognized by others, it often has a tendency to come out physically. Some of you may have been camp counselors, and when I'm teaching my class on this, I always give the example that who sees the homesick kids first, and it's usually the camp nurse. And the kids aren't saying, I'm homesick, but they're coming into the nurse with headaches and all kinds of aches and pains, because again, it's one of their ways of manifesting grief. Anyway, in Nichols' research, in a time when this grief and loss was not acknowledged, one of the things that often occurred is that the people would report, these mothers would report physical pain. And I wish I could see all of you, and I wish I could ask you for your hands up and ask you to interact, because it's always interesting when I ask where do people experience this pain, the guesses are usually very obvious ones. They often will say, well, they must have experienced it in their heart, in their breast, and that comes out as number 2. Or how about their uterus? And again, that comes out as number 3. And if you hit the slide again, where they experienced mostly was in their upper arms, the muscles you would use to lift and to hold the baby. So it really points out the importance of really looking at sometimes the physical manifestations of grief, particularly in populations where, or in situations where those losses aren't acknowledged. And therefore, because the emotional pain is not acknowledged, it becomes physical pain. In any case, it's very important when you're counseling with people, next slide please, to always assess health. And just hit that once, because physical symptoms have to be assessed by a knowledgeable physician. And as you hit the second thing, we can see why. Years and years ago, one of the first persons doing research in the field of grief, Colin Murray Parks, a man still doing productive work in his 90s, pointed out what he called the broken heart syndrome. And his study of widows and widowers, especially widows, showed there was a tremendous high mortality rate and morbidity rate in older widows, particularly, and that many of them died within a year of their spouse's death. And that's been validated by research and by evidence. And often that higher risk of mortality is really due to 3 things. One is what we call the joint unfavorable environment. And what we mean by the joint unfavorable environment is that most people today die of chronic conditions, and most of these chronic conditions are strongly affected by lifestyle factors. So, if you're eating a bad diet, chances are your spouse is as well. If one spouse is smoking, the second spouse is dealing with secondhand smoke. Another factor that contributes to that mortality is stress. Grief and the loss, particularly of a spouse, is highly stressful. And when your state of health is more fragile, that can affect it greatly. And then finally, there are lifestyle changes. Maybe when your spouse was alive, this older woman was making good, healthy meals, but since the spouse has died, she's basically eating out of cans or something like that. Or maybe they took a walk every day, and now they're not doing that. So again, one of the things that I always do in my grief group is that one of the sessions is simply on stress reduction, helping people to manage stress, and then also looking at those lifestyle changes. And again, if we can move on to the next slide, it really is important that when you run programs, particularly with older widows, that grief counselors should, for example, emphasize self-care and health promotion, especially, again, for vulnerable populations, older persons, persons with chronic conditions, those kinds of things. So again, we want to be very sensitive to the physical dimensions of grief. We want to encourage people who are experiencing physical symptoms to go to physicians who will acknowledge and recognize that and understand that it can be a result of grief. One of my favorite stories is a former student of mine, and she talks about the fact that when her spouse died, she had tremendous pain in her back and her neck. And when she went to her physician, they did all the tests, they couldn't find anything. And finally, the physician said to her, Rita, listen to your language. And she listened to her language, and she heard him say, and she was a younger widow, you know, ever since Tom died, everything's on my neck, everything's on my back. And she realized she was somatizing her pain. So again, we want to be very careful of the physical. We also want to be fully understanding of the emotional as we move to the next slide. And again, first of all, hit it one more time. One of the most pervasive, and in some ways, as we're going to see in the next slide, one of the most dangerous reactions is guilt. Some of you are old enough to remember that old song, Love is a Many Splendored Thing. Well, I'm going to tell you from the field of grief, guilt is a many splendored thing. We can feel guilty about all kinds of things. We can feel guilty that we caused the death. I should have brought him to a doctor sooner. I should have made him stop smoking. And again, you know, one of the things to always remember is guilt doesn't have to be rational to be real. In other words, just because really there's no connection doesn't mean we experience it. Other people may experience a cultural role guilt. And a cultural role guilt is that that you feel I should have been a better, and you can fill in the blank. I should have been a better mother, father, sister, son. Other people will experience what we call moral guilt, and that means that they'll look at the death as a kind of punishment, a kind of cosmic guilt. This is a punishment for something I did years ago. When I was at Sloan, my first work in the field was at Sloan Kettering with children who had leukemia. And one of the kinds of comments that was quoted to me, I was a chaplain at the time, most often was the comment, the sins of the fathers will be visited upon the children. And every parent had their own particular kinds of situations. And then, of course, there's survivor guilt. It should have been me, often experienced by relatives, particularly older relatives, sometimes by siblings. Some of you may remember the film Ordinary People or Stand By Me, both of which dealt with grieving children. And both of these children experienced survivor guilt. They felt that their parents would have preferred if one of their siblings got sick and died, it should have been them. One of the children got sick and died, it should have been them. And then, of course, we have recovery guilt, where you feel you're doing too well. And then grief guilt, where you feel you're not doing well at all. And again, you can have all of these types of guilt continually. We also can experience, the next slide, please, or hit it again, relief. Sometimes that's a cause of guilt. Sometimes the relief is altruistic. I'm glad his suffering is over. And sometimes it's relationship. It's been a real, caregiving, for example, can be very difficult and very time consuming. And it's natural at the time of when somebody dies after you've had extensive caregiving to think that, well, maybe there are other things, it's a relief. It's good for him and it's good for me. And that's what we call the dual. So again, and as we continue, just hit that slide again, please. Anger is a very common response. We have this tremendous feeling of anger, sometimes even directed at the person. You should have taken better care of yourself. We can have a feeling of emancipation. That's the sense that death has freed us. Maybe you were in an unhappy relationship. Maybe it's an abusive or difficult parent. And all of a sudden, when that person dies, we feel emancipated. Continue, please. Sadness and loneliness, very common emotions we associate with grief. Yearning, we wish that person were around. We wish he or she were still with us. Next one, please. Fear and anxiety, very, very common. And here's one, the next one we don't talk about a lot. And you rarely see it written in the literature, and yet I think it's really important, and that's jealousy. We may be jealous of other relationships. Why did my husband die or my wife die? We got along a lot better than they did, or why my child. When I worked at Sloan Kettering, I used to have a father who used to leave news articles from the New York News in those days on my desk every morning. His 14-year-old daughter, a lovely, bright young girl, was dying in those days of leukemia, and he would leave articles about 15-year-old and 14-year-old delinquents who had done great damage. And the question was, again, why not they? If God was choosing someone to kill, to give it horrible disease to, why not them? Why my daughter? And then finally, we may experience what we call positive emotions. Just hit that one more time, please. And that's that, and I don't mean by that the sense that we're glad somebody died, but I mean that we might have just emotions that are more positive in nature. I've done a lot of work and a lot of studies of caregivers, and it's not unusual for caregivers to have a sense of not just relief, but also of pride. I never thought I could keep him home as long as I did. I never thought I could change diapers and do all the kinds of things I had to end up doing. A number of years ago, a good friend of mine died, and I was a godson to his son, godfather, I should say, to his son. And his last request for me was to keep an eye on his child and to be a fatherly influence, paternal influence to his child. And I remember looking at that boy who had just turned 4. Literally, the person died the day before his son's 4th birthday, and having this tremendous feeling of protectiveness and love toward this child that I had hardly ever met. And just saying, don't worry, I'm going to be there for you. I'm going to keep my promise to your dad. So again, we can have positive emotions as well. And sometimes that's important because sometimes people will make questions about that. And then, of course, I just want to go back to what I had said earlier, that, that again, if people have high levels of guilt, that's something you have to watch, because, studies have shown that can be highly destructive and lead to complicated grief. So, some guilt is in fact very normal and very natural, but if people have excessive levels of guilt, we really want to be very careful about that. Next slide, please. We also experience grief cognitively, and that can include depersonalization. How many times have you sort of walked around when you've had a loss in a kind of fog? You don't know, you get in the car, you drive someone, you don't even recognize that you're there. You can't even remember the journey. Next slide, next hit, please. The disbelief and denial, continue, please. We just can't believe it. And I'm going to ask you the next one too. Another thing we can do is we can idealize the person who died. They become the perfect person, and that's problematic in some ways because grief is really about letting go of the person. It's about recognizing the natural ambivalence in relationships, what we miss about a person and what we don't miss about the person. And when we idealize that person, that they've never done anything that annoys us or anything that irritates us, it can really interfere with the grieving process. And of course, it can make life difficult for survivors. So if you're the brother of an idealized child, you are always being compared to an impossible situation. And then sometimes too, you can idealize behaviors that are really problematic. One of my real failures, one of the instances I looked down and said, I wonder if there's anything else I could have done, was a young man who came to me at 13 years old, sent by his mother, whose two brothers had died of overdoses or drug-related deaths. In one case, an overdose, and in the other case, essentially falling asleep and nodding out in the snowbank and dying of hypothermia. But in any case, this boy idolized it, and I never could break past that defense, and ultimately he too died of an overdose some 20 years later. And then, of course, the opposite of that is demonization. Maybe we've had an abusive parent, and we hate everything about that person. We've demonized that person. But again, much like idealization, grief means coming to terms with what you liked and what you didn't like about that person. So even demonization is sort of the complementary process to idealization can interfere with our grief. Continue, please. Of course, we can be preoccupied with the deceased, constantly thinking about them. Continue. We can have confusion. We can be disoriented. Continue. We can have obsessive thinking, often focused on preventability. This is the very dangerous if only. We can have an inability to concentrate, an inability to focus, and sometimes kind of search for meaning, like, why did this happen? I just want to make two other points. If you look at the issue of confusion and you look at the inability to concentrate or focus, one of the things I often recognize, and I tell people, if you have a child who's being assessed for special education, it's really important to do a loss inventory. Same if you're assessing someone for dementia, because these things, again, it's important to know if they've had a loss recently, because that can affect your evaluation. Continue, please. And then, of course, we can have what we call our extraordinary experiences. And these two are often very normal and very natural. And if we move to the next slide, these extraordinary experiences, and again, this is work that's been done from Lou LeGrand, and just hit till you get to Lou LeGrand's name. I just want to describe all of these. One of them is a sense of presence, where we just kind of feel the person as present, nothing specific. Others may have actual sense experiences of that person. One of the most dramatic experiences that I had early in my counseling was a woman came to me and said that her daughter had died, and she smelt the perfume that she had put on her daughter, and even though she no longer had that perfume in the house. And often these kinds of things can involve any of the senses. We can have experiences that are symbolic. So, for example, the reason I have this hawk here is one of my clients was a woman whose adolescent son died. And she would talk about coming to me, and before she came to me for counseling, she would always stop at the cemetery, which was on the way. And one day she said, as she came to the cemetery before coming to me, and she went to her son's memorial stone, there was a hawk perched on the stone. And it didn't run away as soon as he saw her, or he cocked his head a little bit, looked at her, and then slowly flew off. And then I said to her, did that have any experience or meaning for you? And her response was, his nickname was Hawk. And then there were third-party experiences where somebody else says something that sounds like the person would say, or validates an experience. My son was very, very close to his grandmother, and actually lived with her for a while when he moved back to the city. And one of the things that was interesting is when she died, he took comfort from the fact that she was now with her husband, and he was her lifelong love, literally from high school. And one day, one of the neighbors came up to him and said, Michael, I had the most wonderful dream last night. He said, I saw your father and your grandfather and your grandmother walking hand in hand down the street. And to my son, that was a very reinforcing experience. And then finally, we can have dreams. And if we can move to the next slide, these dreams, very common experience, can be of two types. The first, they're very common. The first can be what we call basic grief dreams. These are often very fragmented. They're filled with symbolism. One of my clients talked about the fact that that when her mother died very suddenly, she would have this dream, and this dream was that she'd be on a plane with her mother, and the mother would go up to use the restroom, and then she seemed to be taking a long time, and then the announcement came that we're planning to land and everyone should go back to their seats, and in the dream, this person asked the person the stewardess, the flight attendant, to check on her mom, and she was told that there was nobody in the restroom. And one of the ways we dealt with that dream is I asked her to title it, and she titled it Vanished in Thin Air. And then she recognized that that was pretty much the experience that she had about her mother, that all of a sudden she was there and then she wasn't. And then the other kind of grief dream, if you hit that one more time, can be what we call visitation dreams. These are more vivid, they're easily remembered, they're clearly interpreted. And this is where the person comes back and says, make sure you take care of the grave, or make sure you do this, or make sure you do that. And again, as we move to the next slide, when you're dealing with these extraordinary experiences, recognize they're relatively common. About 60% of people will report such experiences. And again, some cultures put a great deal of emphasis on them. And so those that do, they're often more common than cultures in which these experiences are not really looked for or expected. And if we continue to the next slide, I just want to make a few comments about these. And again, just hit them till you get to the end there. What I like to do is I like to solicit these, because many clients have a kind of dual response to these. They're sometimes frightened by the experience, but often find it very positive. So again, I will often say, clients have sometimes, or people have sometimes shared with me experiences like such and such and such and such. Have you had this kind of experience? And then allow the client to interpret it. Most of the time, clients will interpret these experiences very positive, but not always. Sometimes it may be negative, where you have to help them look at that in a different way, or maybe even form some kind of intervention. I had one boy whose father died of alcoholism, and his father was very frightening to him, both when he was drunk and then when he was dying, and had delirium. And so we had to create a ritual where he could reconnect with his father and get rid of some of the bad feelings he had about his father's. And other clients may feel bad that they haven't had such experiences. And again, we might try to suggest things that they might do. It might be things like simply writing a letter of what they would like to say to the person, or all kinds of things like that. So again, it's important to explore extraordinary experiences. Next slide. As we move on spiritually, again, grief affects us spiritually. In some cases, it may lead to a struggle with their faith. They may try to search for meaning. What does this experience really mean to my beliefs? And in some cases, it can change spiritual behavior. Some people may be more closely connected to their spirituality. Others may feel less so. And then, of course, there are behavioral manifestations. We may behave in different ways. We may cry. We may withdraw. We may be overactive, constantly trying to do things to avoid our grief. Some people may avoid reminders of the person who died. Others may seek them, and certainly it can affect our sexual behavior. So these are all ways that our grief will be, and these are all what we call typical grief reactions. Next slide. And some of that may even be humor, and just hit that a couple of times. Humor can sometimes be evidenced in grief. And again, just like crying, humor is an effective way to release emotional tension. The problem with humor, though, is that humor can sometimes alienate others who think we're making fun of their loss, or deflect potential support. The reason I have this home improvement episode is there's a wonderful episode there where the boys are dealing with the loss of their grandfather. And the middle child, Randy, is constantly making jokes about it. And then finally he looks up and says, I don't even know why I do this. And what he's doing is just trying to deflect some of the pain. Continue, please. We also see that, again, not everybody seems to have an intense reaction to loss. Some individuals have very minimal reactions. If you want to read more about that, I would suggest Bonanno's book, The Other Side of Sadness. And again, the reason their reactions to loss, even significant losses like that of a parent or a spouse, is varied. Some kinds it's situational. They may have had fewer losses or fewer stress. They may not have, the death has likely not been so sudden, so they've had a chance to say goodbye. They often have an intrinsic spirituality and good psychological health. So again, we sometimes see people who don't have it, and we can learn from these resilient grievers. They often had an optimistic mindset. They were able to respond to changes, and they believed that even in the worst episodes and the worst things, they could learn and grow, and they engendered, very positive memories of the person that died. So again, all of this fits into the pattern of typical grief. As we move on, we also recognize grieving styles, and this really begins with the work that Terry Martin and I have done together, and it started as a study of grief and gender. And what we tried to do is we were trying to see if men grieve differently than women. And the answer we came out with is some do and some don't. So our work evolved to talk about grieving styles that are influenced by gender, but not always determined by gender. So for instance, you may find women intrinsic instrumental grievers, men instrumental grievers, and the like. And we recognize that culture is a factor here, that temperament or personality is a factor here, and there are other factors as well. So for example, we looked at grieving styles as kind of a continuum. And on one end of this continuum are intuitive grievers. And if you ask intuitive grievers about their experience of grief, they're likely to say things like, I experienced as feelings of sadness washing over me, feelings of anger, feelings of guilt. And if you ask them what helped, they will often say, I needed to unpack these feelings. It was good to speak to a counselor or speak to a confidant or be in a grief group. On the other end of the continuum were instrumental grievers. And instrumental grievers really were more thought and action oriented in their coping. So if you ask them how they experience grief, they might say, I just kept thinking about the person a lot. I kept going over things in my head, or I wanted to do something. And again, what often helped is in the doing. One of the people we interviewed was a father whose 16-year-old daughter died. And he talked about the fact that when he buried his daughter, he ended up, after his daughter was buried, painting the neighbor's fence. Her daughter had a car crash and rolled over, and it was very important for him to repair that fence. And he said that was the most helpful thing and therapeutic thing I did. So he actually worked through his grief. And then there are also dissident grievers who are really, these are the ones who are really submerging their grief. So these are people who may have strong feelings of grief, but act as if they are resilient, but they're really repressing their feelings. And again, all of this is part of the natural and typical ways that people grieve. Nothing up until now is problematic. But now we get to some problematic and dangerous signs. So here's the yellow light, the warning signs. And this can be where somebody takes on the behavior of the deceased. And again, This may be that they have a hard time letting go of that person. They almost in their head want to become that person. But sometimes it can be very natural and very normal. Think of, for instance, the father who's the disciplinarian in the family, but yet once he dies, the mother has to take on more of that role. And it's very similarly with the experienced symptoms of the deceased illness. Sometimes, again, that may be an over-identification, but sometimes they may have similar diseases because of the factors that we talked about that affects their health. But the next slide really shows, these are red lights. These are the clear dangers. Self-destructive behaviors, including substance abuse, behaviors destructive to others, or where grief is really disabling. In other words, you can't function in your family, in your school, or in your work, or any one of those, or all of those. These are signs that you need help. These are signs that say, don't walk, run for support, wherever you're going to find it, counselors or the like. These are signs of what we call atypical grief, and they're danger signs. Obviously, one of the things that's interesting, and we can hit that slide again, is that grief can be related to depression. Freud wrote it actually about 100 years ago, slightly over 100 years ago, I think in 1919 or 1918. Freud's Mourning and Melancholia was really the first modern article on grief, really the beginning of contemporary grief studies. And Freud's goal there was to differentiate grief from depression, recognizing that both can share common symptoms or manifestations. And Freud's definition is that grief is more transient and generally doesn't involve a loss of self-esteem. Freud attempted to set this up, but it's something we're still arguing about. And if you followed some of the debates about DSM-5, one of the things that really was very problematic to some people was the end of what was called the Bereavement Exclusion in terms of looking at grief, that that you couldn't diagnose somebody with depression before a certain time period after a significant loss. And while many of my colleagues were against it, I was one of the few who was really in favor of ending that exclusion. And the argument I would give is that in many cases, bereavement can really trigger a depression. And if it looks like depression, if it acts like depression, the old expression, if it looks like a duck and acts like a duck, let's call it a duck. Let's call it depression. So there is a relationship between the two. Next slide, please. And so as we go on, and again, I just wanted to make that last statement here, that, that again, if someone is having a depressive reaction to grief, and they have a clear depression, and the DSM-5 does a very good job of really focusing on that. They need additional help, and I would hold they need both medication and therapy. Next slide, please. So, how do we assess grief? Well, the answer is there are a lot of factors we have to look at. And the first is just the nature of the relationship. What kind of relationship is it? It's different to lose a mother, father, parent, child. Doesn't mean it's easier, and some of the early research in the field kind of said, well, what is the toughest? And I always like what a colleague of mine said, Rabbi Earl Groman, the toughest loss is the one you're dealing with now. We can't compare losses. It's terrible to lose a child, it's terrible to lose a parent, it's terrible to lose a spouse. But each of those relationships creates different kinds of issues and different kinds of difficulties. Next slide, please, or next hit. Second of all, what's the nature of the attachment? Is it a close attachment? Is it a highly dependent one? And again, we're going to see that that's problematic, or a very ambivalent one. So we want to look at how, what is the kind of attachment the two people had. Next, please. we want to look at the developmental level, and we're going to make a few comments about that in a few minutes, but obviously where somebody is in their development is going to affect how they respond to grief. Next, please. The circumstances of the loss. Did somebody die of a long-standing disease, or did somebody die very suddenly? And again, neither one is necessarily easier. It's just that they're very different and they create different issues. I'm right now doing some evaluation of a homicide, and again, in a homicide, you know, there's the issue of media, there's the issue of trial, police work. All of those can complicate the loss, but every loss can get complicated in its own way. What's the personality and the history of the individual experiencing grief? And again, pre-existing mental problems, depression, anxiety, can often lead to more complicated responses to a loss. Next, please. What kind of family and social support does the person have? A number of years ago, Colin Murray Parks did a wonderful piece, and he asked the question, who needs bereavement counseling? And the answer wasn't too surprising. People needed bereavement counseling and benefited most from it when they didn't have strong support, informal support systems, when they didn't have confidence, family, or friends to really communicate with. And again, the key is that they can communicate them. So a college student who's 500 miles away and has a serious loss may have a wonderful support system among their high school buddies, but they're not there. So we always want to look at what kind of support are they getting, where they are, as they are. And then we want to look at culture and spirituality. You know, how does that influence their grief? And I always ask the question, not necessarily in such a coarse way, but what do I need to know about your culture, spirituality to work with you effectively? I might ask a little bit of how does your faith speak to you, or what is your faith, or what are your beliefs? I might ask questions on good way to get to culture is to ask questions about how does your family do things, and you know, and the like. But you want to essentially say, how are culture and spirituality, whatever that person's spirituality is, even if they're non-theistic, or philosophy, if people prefer, how does that really help them or hinder them as they deal with grief? Continue, please. And then you want to look at concurrent stresses. What else is going on in their life? You know, so for example, it's hard to deal with grief, but it's harder to deal with grief if you're also dealing with the loss of a job, or relocation, or a fire, with all the losses that occur in a fire. So what else is going on in the person's life? And finally, if we want to look at one, we want to look at health and coping abilities. You know, again, if we're healthy, if we're effective copers, it's going to be easy. So as we assess an individual's grief, these are some of the issues we want to consider. Next slide, please. Again, you know, we want to stress that grief is a very individual reaction. My mentor, Dr. Grohlman, used to always say, grief is as individual as fingerprints. Next slide, please. And again, if you look at some of the major predictors, one of the studies that found that, you know, that again, conflict, dependence, ambivalence, excessive ambivalence are good predictors of complicated grief. And again, pre-existing conditions like depression and anxiety are also likely to be triggered. And then, you know, trust yourself if you're a therapist or counselor. When a client walks in the room, we often have a kind of gut feeling of how they're doing, and sometimes we need to trust our gut. Next slide, please. And then, of course, we also want to include attachment styles. You know, and again, there's some wonderful books on attachment-based grief therapy, and often people who have a very secure attachment have the resources to handle grief. People with more difficult types of attachment issues, clinging attachments, avoiding attachments, disorganized attachments, they may have more difficulties. So again, people who you know, who kind of find it difficult to attach to people may need permission to grieve, and people who just kind of cling to people who are highly dependent may need some help in stopping to grieve. And again, people who just really don't have good attachments, who have what we call a disorganized attachment style, may need both. So keep in mind attachment. Next, please. As we continue, we also want to look at the environment. You know, again, where is the person? So for example, and just continue down on that one, please. What is the level of support do they have in the family? If they're in work, are supervisors flexible and supportive? Are there resources in the larger community? How accessible are they? Are there, for example, grief groups? I saw one of the questions come up as to whether I lead a grief group now, and the answer is not currently, but I have for many, many years led a grief group. So again, next slide, please. And again, grief reactions are influenced by developmental processes. We could spend a whole session on looking at grief in the lifespan, but I wanted to make a few comments about children's grief, just to bring it in there very, very briefly. But again, this can be an entirely different session. So as we look at the next slide, one of the things we always have to look at are what we call developmental expectations. You know, there are certain losses that are expected at certain ages. In midlife, as we reach midlife and later life, depending on the age when our parents age when we were born, we can expect to lose our parents. You know, I'm into my 70s now, and one of my siblings has died. I hope my sister lives a very long time, but she just turned 80, and you know, these are eras that eventually, you know, we're going to die. But out of order deaths can be particularly traumatic. So for example, if we have the death of a parent when we're 6, or the death of a sibling when we're 10, these really challenge our beliefs about the world, that it's safe, that it's predictable, that it's benevolent, and they complicate development. Now, this doesn't mean that other losses that take place that are quite in order are necessarily easier, but it does really point out the difficulty of out of order deaths. Next, please. And so children's grief can affect us in a number of ways. And again, I always like to say, and you can just plug those slides in, children grieve as we grieve. But there are a couple of differences that we ought to just highlight. And the first is that children can sometimes re-grieve what we call earlier losses. And what that means is children have to be about 6 or 7 before they really get, sometimes even later, it depends on the individual level of the child, what death really is. And so, you know, so it's not unusual that a child may experience an early loss and then later on in life revisit that loss. For example, you know, I told you my godson's father died the day before his 4th birthday. And he dealt with his grief then. But when he became about 8 or so, he began to realize different dimensions of that loss. I'm never going to see my dad again. You know, he had a much more mature understanding of death. So it brought back all of those experiences. And then when children reach adolescence, they often ask the question, you know, how am I like my father? You know, part of our own identity. How am I like my father? How am I like my mother? How am I different? And again, the loss of a parent at prior to that may cause them to, you know, say, well, what do I know about that? To revisit the loss. David Crenshaw also points out that an early significant loss can really affect our ability to connect and really create attachment difficulties that are different. So, for instance, we often have what Crenshaw calls the crisis of impending connection. David Crenshaw worked a lot with foster kids and kids in institutions, And he pointed out that lots of these kids had early losses, and so they go through a kind of interactional dance. When they get close to somebody, they get scared, and they say, whenever I get close to somebody, they die, so they sort of try to push them away. And again, children's manifestations may include some different ones, often the very same reactions, but some different ones than adults as well. They can act out, they can have sleep disturbances, they can regress, they can have accidents, and then changes in behavior and grades, not explained by other developmental factors. So all of these are things to be important. And again, we're giving this short shrift, but we could talk a lot about grief in the lifespan. Next slide, please. But we always have to remember that when you're dealing with children and adolescents, grief takes place in a family context. And again, the Harvard Bereavement Study was one of the most significant studies of children's grief, and it said the best predictor of a child's adjustment, this is a child who's lost a parent, is the ability of the surviving parent to function. So again, it's always important to recognize, and there's a whole group in Arizona that has developed a wonderful program on, family-centered grief counseling, where when the child goes into a grief group, the parent also goes, the surviving parent also goes, and they talk about how they're dealing with their grief and how they're dealing with their child's grief. Again, very, very critical to recognize that family context. Next slide, please. So, how do we understand the process of grief, and what are some of the theories and metaphors that help us explain that? We can continue then with that. Stage theories were very, very attractive early on. Robert Niemeyer once said they almost have the narrative structure of an epic journey. Think of Lord of the Rings. They offer a wounded protagonist, a predictable set of events, and the possibility of a happy ending. And again, some of the earliest theories about grief were stage theories. Next slide, please. For instance, one of those was Colin Murray Parks, and Colin Murray Parks, as I said, is the still surviving and still productive grandfather of grief studies in many ways. He was the bereavement counselor at St. Christopher's with Cicely Saunders. Some of you may know that that's the first really hospice program. And he talked about grief as being kind of a wound. And again, healing could be healthy, or sometimes the wound gets infected. And he looked really, his initial work in the field, next slide, please, was a kind of stages. And again, would you hit that till it hits it? And he said originally people went through shock and numbness, and then anger, and then despair and depression, and then what he called recovery and detachment. A new homeostasis, as he's put it, to remember to live without the person. And one of the things that was interesting about Parks is even early on, he really talked about the possibility of growth and how people can grow. Parks, by the way, his work has continued to develop and no longer necessarily holds to these stages. Although, Kubler-Ross's work really sort of probably developed from Parks, and her stages of dying were applied to grief by one of her students, Kessler, as well as, and she was involved in that as well. So again, stages of grief were the initial sort of reactions, but next slide, please. We tend no longer to hold to stages. We tend to see grief, as we're going to see in a future slide, as very individual. Another person who did some very interesting work early on was Katherine Sanders, a colleague and a delightful friend. And she really, she was herself a bereaved mother who got into the field after seeing her son literally killed in a water skiing accident as she watched. And so she personally, and I like to say professionally, offered a model of grief as transformative. Next slide, please. And Katherine, again, just hit that through. Said, and again, this was not quite yet. Sanders said that people went through a series of phases, and this was research-based. First was a sense of shock, and then this very painful period that she called awareness of loss. And she had a grief experience inventory that allowed her to measure this, and again, scores were very, very high here. This was when the pain was very, very raw. And then she said people went through a period of what she called conservation withdrawal. And this was a period in which people, their grief scores were lower than they were before, but still relatively high. And they generally described it as, I do what I need to do to get through the day. So I just kind of, I just kind of get through the day, and that's all I want to do. I do what has to be done. Very little pleasure in what they're doing, very little sense of pride. They're just kind of making it through. Next slide. And Sanders said people in this phase have three choices. One choice is to die. They just don't take care of themselves. They don't watch themselves. The other was they just stay there. They maintain the status quo. One of my counseling cases once came to me after the death of her sister, and her sister was very, very close. At one point, as we were approaching, as we were continuing in treatment, she said, when my sister died, it was like I was watching. My life with my sister was like they lived together and did everything together. So it was like somebody, like being on a situation comedy. It was colorful. It was fun. And she said when she died, it was like somebody had pulled the plug. And she said, you gave me back the TV, so to speak, but now it's black and white. And I said, we can get the color back. And she said, no. She terminated therapy and said that would belie my sister's life. In other words, she was willing to stay there and say, I'm going to live a life in grief. And then the final choice, next slide, is the decision to change. And some people will say, no, this is not the way I want to live life. Continue to the next slide, please. And she said those people often describe what she called a turning point experience in their lives. One of her examples was a grandmother who would, every time her husband had died 6 years ago, and every time she saw her 5-year-old granddaughter, which came every day, she'd start crying because her husband never got a chance to see their beautiful granddaughter. And then one day, as she talked to Katherine Sanders, she said, as my grandmother left that day, as my daughter left that day, I heard my granddaughter say to her, is that all grandma does, just cry? And she said, I didn't want to be remembered as the woman who just cried. And so others will experience a sense of renewal. And later, Katherine even talked about what she called the sixth phase, fulfillment. And that was where you have a sense that it all comes together. It all makes sense. Like a carpet that's, all the different faults become interwoven into the pattern. And you can't imagine life. You would never want the loss, but somehow your life has changed dramatically because of that loss. And you can't see what life would be like without it either. A kind of strange pattern that it seems in its own way to make sense. Continue, please. Again, another approach is what we call meaning construction or narrative approaches to loss. And this is where one tries to, again, find meaning in that loss. And this is the work of Bob Niemeyer, if you want to read more about that. And then continue to the next slide. Meaning may be assigning blame. Why did it happen? Who am I now? What is the world like now? What has come as a result of this? And what do I believe about God? So it can be a very extensive process. Another common model, as we move to the next slide and just hit that till it comes through, is the work of Strobe and Should, what they call the dual process model of grief. And what they basically believe is that we ultimately have to deal with two processes. Continue a little bit more on hitting that. We have one process that's oscillation. And, we have one process that's dealing with the loss. dealing with it. And then another process that deals with the restoration. And what they call the oscillation of between these two processes is very, very normally part of grief. Hit 3 more times, I think. There we go. And that oscillation is normal. To give you an example of that, I had a woman once who came to me and said, I asked her how her day was. First, how's everything going? She said, good. She said, for the first time since my husband died, I balanced the checkbook. And she felt very proud about that. And the next time she came in, she said, when I left you, I thought if John hadn't died, I wouldn't even have to worry about this. That back and forth kind of roller coaster process. And that's very healthy and very normal. If you just focus on the loss, if there's not that oscillation, grief becomes chronic. And if you only focus on the new life, you're inhibiting or delaying or your grief. Continue, please. And then, of course, we want to look at Bill Warden's work. And we're going to emphasize this the next time around because this is really the heart of grief counseling to me. Bill Warden says you have to fulfill certain tasks when you grieve. The first is acknowledging the loss. The second is expressing the emotion that you experience as a result of the loss. The third is adjusting to a changed life. And the fourth is relocating the loss. In other words, having an enduring connection with that person. And then I've added a fifth task to Warden, which is sometimes a loss challenges what we believe. And we have to reconstitute our faith or our philosophical systems that are challenged by the loss. We'll look more at that next in a couple of months when we come back again. Next, please. And again, as you're dealing with clients, it's always important to understand how they look at grief. What's their view of therapy? As we continue, we can see that there are lots of metaphors that are used with grief. Next slide, please. So, for example, I like to give people the example of a roller coaster. Again, very much connected to the Strobe and Should. You go up, you go down. Some are steep, some not so steep. But always be careful with metaphors. I always ask a question: have you ever ridden a roller coaster? And if somebody answers me and says, no, I dread roller coasters, I've always been scared of them, I don't want to say, well, grief is very much like a roller coaster. Then you want to use another metaphor. Some of the other metaphors you might use for communicating this process, next slide, please, are waves at a beach. If somebody knows what a beach is, they come in. Some of them aren't as bad as you think. Some of them really knock you down. Another metaphor, next slide, would be one that I use a lot, and I have a book called, Grief is a Journey. A journey where we don't know where we're going to end up in, and there are all kinds of paths and all kinds of trials. And so that's again another kind of useful metaphor. Continue, please. But again, the important thing is grief is not a time-bound process that ends in detachment. And what I like to say, next slide, please, is that we always continue to have a bond with people. I think that's very important. That that you always, when I start counseling with people, I always say, what are you looking for in grief therapy and grief counseling? And they always want to say, they often say what they think you're supposed to say. I want to move on. I want to, detach. I want to, move on with my life. And I always say, do you really? And most of the time people recognize, no, you're always going to continue to have a bond with that person. I always tell people the first sign that they're doing well is when they can laugh at a story that's now too painful to recall. Next slide. I like to talk about amelioration of grief. And what I mean by amelioration of grief is that the intensity of grief reactions diminish over time, that individuals function as well as they did, and we're going to talk about next month, sometimes even better than they did prior to the loss. But that grief has a developmental effect. And what we mean by that is, by grief having a developmental effect, is that years later, You can be touched by it. It may be you're 10 years old when your father dies, and 15 years later, you're going down the aisle with your uncle or your cousin or your brother or your mother or your stepfather. And all of a sudden at that moment, you really wish your father were there with you. That's part of amelioration of grief. We're always going to have these times. And again, next slide, please. When I terminate with people, I always try to say, when are you likely to experience these, and normalize them? So say 10 years later, when their first grandchild is born, they recognize that sense of loss, and they normalize it. Next, please. And again, the types of connections we have them in our memory. Always remember, people, we have them as part of our biography. If you knew me, you'd see some of my father's and mother's characteristics in me. They're my sister. They've all influenced my life. The legacies and liabilities. I don't know if you can see this, but here is my list of things to do. My dad always made a list of things to do. I do it too. The spiritual connections, and of course, what we've already talked about, the extraordinary experiences. We stay connected to that person. Next, please. Not every connection is positive, though. We do want to be careful of problematic connections. These are where the ghost rules. You know, I promise my spouse I will never marry again, but I really am in love with this person. You know, and we have to make our own choices. Or where there's no acknowledgement of loss. Next, please. Or where it impairs growth. So again, not every connection is positive, and we recognize this. You know, we normally do have continuing bonds, but not all of them really are associated with growth. Next. So again, one of the last things we want to say here is that we always have to look at bonds, continuing bonds in a culture. Next slide. Just fill out this slide, please. You know, it always has to be addressed within a spiritual and framework. If you came to my house and you saw an altar from my parents, coming from a Hungarian Hispanic background, you'd probably think something strange here. But among some people with an Asian background, that would be a very respectful way to acknowledge their relationship. So again, we always have to look at it in terms of a spiritual and cultural framework. Next. We also have to realize one other aspect of that, and that's what we call post-mortem identity. That sometimes, because we do have a continuing bond, as information about the deceased becomes available, it can complicate the mourning process. I always like to give Custer as an example. You know, look at movies like They Died with Their Boots On, and Custer is portrayed as empathic and sensitive toward the Indians and Native Americans, and a real hero. And then if you look at subsequent movies and subsequent histories of it, we've reevaluated him, and we tend to look at him very differently now. One of the things, next slide please, is that Rubin says is that sometimes revelations about the deceased, you know, maybe they had a second family, maybe they were a war criminal, maybe they were a pedophile, can be as traumatic to survivors as traumatic experiences of the death. So post-mortem identity is something we really did look at. And we'll get to questions in just a second. I just want to summarize this finally and say that some of the aspects of contemporary grief therapy are we acknowledge the variety of losses that engender grief. It's not just death. Any loss that's significant to us, whether it's a divorce, a relational issue, loss of property, can be problematic. We no longer look at grief as a predictable set of stages. We've moved to personal pathways. We've given increased attention to cognitive and spiritual aspects of loss. We increasingly recognize continuing bonds rather than detachment. We increasingly recognize post-traumatic growth, that people sometimes actually do better in grief, that they've learned new skills. We recognize culture. We moved away from universal reactions to really recognizing that how we grieve is very much determined by the standards of our culture. Next, please. And finally, we have eclectic approaches. Yet, there's no silver bullet. There's not one way to do this, but we want to use evidence-based. And I think that ends that slide. So look forward to your questions.
Okay, so Dr. Doka, thank you for that wonderful presentation. Our first question is, you answered the one about the running a group. Second question is, can these symptoms be experienced by adults that have lost custody of their children as is termed as depression? I am not aware as counseling for grief in this setting.
Yeah. It's interesting. I told you about 100 years ago, Freud wrote his first book first article on grief, mourning and melancholia. When I talk about this, I always ask, what do you think his case study was? Freud always started with a case study. And his case study wasn't a bereaved parent, wasn't a bereaved child. It was a bride abandoned at the altar. And I think it took us a long time to really realize what he was saying here. And that grief is not about death, but it's about loss. I've done a lot of work over my career with foster parents. And again, the whole foster care process, from parents to foster children, is just rife with situations of grief and loss. So clearly, yes, there are lots of non-death losses, including losing custody of your children, which certainly can engender grief and what you'd expect to engender grief.
Okay, thank you. Next question. How do you define excessive levels of guilt?
Good question. And again, I would say, it's, I don't know that I can give a quick answer to that, but I would say, number one, trust your gut. And the key question to be asking is, how is this guilt interfering with their life? And how resistant is it to intervention? In our next session, we're going to be talking about a number of interventive techniques that can be used with guilt. Among them are, what I call rituals of reconciliation, writing letters to the deceased, talking to an empty chair, and then sometimes what we would call having somebody sit in that empty chair and having the client sit in the empty chair and respond as they think the person would respond. And there are lots of effective attempts to cope with, lots of effective attempts, I should say, to strategies to deal with guilt. So I would say, if it really is, number one, interfering and disabling, and number two, highly resistant to interventions that generally work, that would show to me something's really going on here.
Okay, thank you. Next question. I work with youth. Parents often share they are concerned about their child's lack of response to a close family member dying. It's possible the child has an instrumental style in grieving, but how might we know if this is the case versus if they are disaffected by it for other clinical reasons? Okay.
I think the first thing that I would want to assess is, what are the grieving rules in the house, and how is grief expressed in the house? So if you have an adolescent, let's say boy or an adolescent girl, and every time she brings up the loss, somebody cries, the child may be getting the sense, or the adolescent may be getting the sense of, I better not talk about this. This is uncomfortable. I think another question I often ask adolescents who, if they're talking about this loss with their peers at all. Sometimes it's easier to talk to peers than it is to parents. But the biggest factor to me would be, I always ask, the difference between repression and instrumental style is, number one, can the person freely talk about the loss using their own language? So it may not be, ever since Dad died, I feel. It may be, I keep thinking about Dad in this way, or I keep thinking, whenever I score a basket, I think Dad would really like that one, So is the person, most people who are instrumental are comfortable about talking about the loss, particularly in their own vocabulary. Second of all, do you see any behavioral changes or any other changes significantly different than what you can expect in adolescence? As kids go into middle school, their grades generally go down a grade. But is it going from an A to a D? That would be more dangerous. Are they acting out in any particular way? So I think there are ways to assess it, but that would be the key issue. Can they really talk about the loss, and do you see any dangerous manifestations that somehow their way of dealing with the loss is in a very dysfunctional way?
Thank you. Next question. Where does grief after suicide fit into this? Implications, complications? Can you talk about this specifically, given this is Suicide Awareness Month?
Sure. Wow. That's a whole other topic in and of itself. But certainly one of the things we know is that suicide is highly complicating, and particularly, particularly apt to arouse tremendous amounts of guilt in survivors and tremendous amounts of anger in survivors. I would say that that the risk of complications in suicide run very, very high, and need to be dealt with. As I said, we need a separate section on that just in itself, but it is clearly a complicating factor, one of the most complicating factors.
Okay, next question. How do you maneuver through barriers of briefly communicated cultural practices, as we don't talk about those that have passed? However, client communicates and experiencing challenges to move on with life and responsibilities as raising their children.
Read that again to me.
Okay, yeah, it's not really a question, but how do you maneuver through barriers of briefly communicated cultural practices, as we don't talk about those that have passed? Okay. However, client communicates and experiencing challenges to move on with life and responsibilities such as raising their children.
Yeah, I would, I would simply, I'd go back to the kind of the model of the dual process and say and again, look at culture, explore culture with them, explore how that may be problematic to them, and really validate the fact that, we can't really, it's problematic to deal with simply restoration without focusing on your sense of loss. The fact that the person's with a grief counselor, to me, would be a very positive piece there, saying that they recognize, and I think just identifying what are the cultural barriers and how are they affecting you.
Okay, thank you. Next question. Grieving may not apply to only those who have died. Any loss can be grieved. Do you see many clients who grieve for losses who are alive, and how do you treat these types?
Sure. One of the books that I've written, and probably one of the concepts that I'm most well known for, is the concept of disenfranchised grief. And disenfranchised grief refers to losses that are not always validated or acknowledged or recognized by others, where we essentially don't have a right to grieve. So I frequently deal with clients who have non-death losses or death losses that may be, at least in the minds of other people, as peripheral, ex-spouses, lovers, things of that nature, because of the nature of my writing and the nature of, who gets referred and things like that. And I handle it just as I would handle any grief, situation, validating that they have a legitimate loss, helping them to explore how they're responding to that loss, what their reactions are, and then helping them find ways to more effectively cope with that loss, utilizing the strengths that they already bring to the table.
Okay, so last question, because we only have a couple minutes.
Okay.
What about compounded grief or many traumatic losses for an individual in a short period of time?
It clearly is a complicating factor. We often talk, and when I talked about concurrent stresses, one of the concurrent stresses there would certainly be multiple loss. So it certainly is a complicating factor. And I guess my suggestion would be in therapy to try to handle each of those, to help them to name and to identify each of those losses and understand what they mean to them individually and how they interact with their other losses at this current moment.
Thank you very much, Dr. Doka. We certainly enjoyed that presentation. Thank you for everyone for joining us today. It has been our pleasure bringing this session to all of you. Today's presentation, slides, and recording will be available on our website. We will also be taking an inventory of all the questions that were not answered, and we're going to try to answer them later and upload them on the website as well. So just a reminder, we have our next session today is our breakout rooms. So please join us for the breakout rooms and the networking opportunity. Again, thank you, Dr. Doka. That was
Thank
wonderful.
you. It was a great honor to be with everyone there, and I certainly look forward to seeing them in November.
And everyone, please fill out the evaluation. Our network is funded through SAMHSA, which allows us to provide this training. The QR code is right there, so please do fill out our evaluation.
Thank you.
So thank you, Dr. Doka. Everyone, have a good day.